live. Hello everybody. For those of you who don't know me, my name is Dr. John Kennedy. I'm the Medical Director of Therapy Fertility. Now, we did an Instagram live, was it last week? We answered a few of your questions. There's been a few more questions that have come in since then, so we're going to try to answer some of them. And in the last 24 hours, there have been a lot of questions about ovarian cysts, PCO, PCOS, and that whole axis. So what I'd really like to do is today is just try to take a few minutes, break down some of the confusion that exists around PCO, PCOS, and ovarian cysts, just without discussing obviously anybody's individual cases, which clearly I'm not going to do. Talk about some extra information, some steps that you could take if you've been given this diagnosis or what impact it can have on your ability to conceive. Okay, so the first thing I'm going to try to do is define what PCOS is. And straight away I can tell you, I'm not going to be able to do that properly. PCOS stands for Polycystic Ovarian Syndrome. PCO stands for polycystic ovaries. And back in the dim and distant past when I was going through my training, we used a term that you don't hear anymore, PCOD, Polycystic Ovarian Disease. Now, back in the day, in order to be told you had PCOS or PCOD, you needed to have loads of specific things. You needed to have no periods, you needed to be overweight, you needed to have extra hair growth, possibly vocal changes. You needed to have a very characteristic appearance of multiple small follicles in the ovaries on an ultrasound scan, and you needed to have specific hormonal imbalances with altered LH-FS ratio, elevated testosterone, and some other hormonal findings. Very, very few women actually hit all of those markers. So 90% of the time when I'm talking to somebody who's been told they have PCOS, they've also been told they don't have PCOS. By one medical practitioner, they've been told they have it. By another one, they're told they haven't. They don't have it. And that's because what we call PCOS is actually 3 or 4 or even more conditions that are all crammed into the same bag. I talk about this in some of the podcasts. There's people who are overweight and have no periods with PCOS, and there's people who are very thin, who have frequent periods with PCOS, and everything in between. The other thing to really understand, and this is absolutely critical, is the name is wrong. Polycystic ovarian syndrome does not mean you have lots of cysts in your ovaries. Okay? These are not cysts at all. They're very small, very immature antral follicles. They aren't cysts in any way, shape, or form. And for some women, instead of getting a regular cycle, one of these follicles growing, maturing, and releasing an egg, they just stay at the same small stage all along, and you can get no periods, and your estrogen can be low, and it can cause various issues. So PCOS and ovarian cysts are 2 completely different things. Now, it is wildly unfair to expect somebody who doesn't work in this field to understand that, because by its very name, PCOS says you have lots of cysts in your ovaries, polycystic ovarian syndrome. Guys, all I can do is tell you it's wrong. I hate the term. I've always hated the term. Up to 40% of all women can be said to have some degree of what we now think of as PCOS. Anything that affects 40% of the population is not a general or generic disease. It's just a variant of normal. So we need to move away from the label, and we need to look at people in a slightly more bespoke fashion. It doesn't matter if you have this label or not. What does matter is, what's your medical history? Are you overweight? Are you underweight? Are you getting regular periods? And specifically, what's your ovarian reserve, especially as it relates to your AMH level, which is a blood test, and your antral follicle count, which is a count of the number of small follicles in the ovaries. So one feature that people who have been told they have PCOS is that they have an appearance on an ultrasound scan of having lots of these little follicles, not cysts, follicles. And that can be one marker of it. But if you're 28 years old and we say a normal number of antral follicles, when you add the left and the right ovary together, is between 10 and 20, but you've got 35 follicles, does that mean you have PCOS? Not really, no. Maybe if you've got no periods, maybe if you had some other things, you might trend a little bit more in that direction. But even then, I'd still urge you to move away from the label and move away from the diagnosis, because all it will do is add to confusion. It will try to lump you into a group with a bunch of people whose symptoms and history and problems do not match yours. We need to be more individualized about this. Okay, so hopefully that'll clear up that bit. Now we talk about ovarian cysts. What are these? These are big fluid or other filled structures in the ovaries. So they're bigger than follicles and they can represent a bunch of different problems. Most of them are simple and benign and just contain fluid. Some of them can contain dermoid cysts, and these are nasty things that contain teeth and hair and goopy stuff. Some of them can be cancerous, although that is thankfully rare. Some of them can be related to endometriosis. And depending on the type of cyst that you have and your history, it can have an impact on your fertility, absolutely, or it may have no impact on your fertility at all. Some people will develop a follicle, that follicle won't rupture, it will turn into a cyst, and it might persist there for a little while and then go away by itself, and everything in between. So it's a very, very complex, individualized area. But cysts are not the same as PCOS. Okay, so we're going to jump into some of the questions here. 30 millimeter simple cyst on right ovary, will it disappear on its own? Will it delay treatment? It'll probably disappear on its own, but maybe an interval ultrasound scan to tell. It could be drained if you were having an egg collection, it could be drained if you're not having an egg collection. The question I would ask is it having an impact on your cycle? If you're still cycling regularly, chances are it's just sitting there, and if it's not changing, I'd leave it alone. It's probably not going to get in the way of accessing follicles if you were to do an egg collection or something like the same. So I don't think it would necessarily delay treatment per se. Do ovarian cysts cause infertility? Potentially, yes. I think you have to judge each case on its own individual merits. If it's a simple cyst and it's just popping up and disappearing, then it's not a concern. Tried to conceive with PCOS, periods every 35 days. So that's interesting. So periods every 35 days. There's more to this question, but I'm going to stop here. Every 35 days probably means that you are ovulating, but you're not ovulating on day 14. You're probably ovulating maybe 6 or 7 days later, maybe on day 21 or day 22. How reliable are ovulation tests? Unfortunately, they're not massively reliable. They're not even reliable in people with regular cycles. They just aren't brilliant. They show positive, but no baby. So in this case, so again, if you have what we call true PCOS, or if you're kind of at the more extreme end of that spectrum, then maybe you've got an elevated LH-FSH ratio, and that's what the ovulation prediction kits are picking up. They're not brilliant tests, unfortunately. If you have a regular cycle, that is, say your periods are coming at the same time every month, then chances are you are ovulating. We can say that with about an 80% degree of certainty. Not an absolute certainty, but an 80% degree. What's the difference between PCO and PCOS, and how can you diagnose the difference? So I think we've tried to touch on that a little bit. PCO, polycystic ovaries, is just the appearance not of cysts, but of these multiple small follicles in the ovaries. PCOS comprises a spectrum which allies not just with the scan findings, but with your own symptoms, your cycle, and other hormonal factors. Fertility tests had high AMH, they suggested PCOS, but my GP ruled out due to only one symptom of it. Perfect example, isn't it? I've been told I have PCOS, my AMH is high, I do a scan, there's loads of follicles, so I have PCOS, but my cycle is regular, so I don't have PCOS. What's going on? This sounds reductive, and it sounds like I'm being evasive. I'm not. It doesn't matter. What's much more important is how old you are, what's actually your AMH, how are you going to respond to treatment? Do you need help to get you ovulating regularly? Is that the easiest lo-fi solution to you getting across the line and having a baby? The label is secondary. And in truth, when somebody tells you have it and somebody tells you they don't have it, I wish it wasn't the case, but they're both kind of right. You know, it's just one of these messy situations we've got ourselves in by failing to adequately tease out these structural differences in these processes. Can a cyst from 16 years ago that has not been painful since cause trouble conceiving now? I suppose it's not impossible, but I would look at all the other factors first. Are the tubes open? Is the sperm normal? Are you ovulating? What's your ovarian reserve? Aside from that, what kind of cyst is it? That doesn't sound like it's a PCOS spectrum kind of thing. It sounds more individualized. High FSH, low AMH, is there a connection? Yeah, and now we're talking about the whole other end of it. PCOS tends to be associated with high AMH, with a high ovarian reserve. A low, very critically low ovarian reserve and a high FSH suggests that the body is working overtime to try to get you ovulating from a very limited pool of eggs. Does it decrease your overall fertility rate? So I think we can talk about that. If you're not getting regular cycles, then yeah, of course, your chances of conceiving spontaneously are reduced. Had an ovarian cyst in March, which had burst by May, had another one on the same ovary by June. Yeah, so maybe you're developing a follicle every month that's not releasing and that's turning into a cyst. Is your cycle regular? How old are you? Oftentimes you see, as the ovaries approach the end of their lives and kind of the early to mid 40s, you see follicles where the egg develops, grow, and not rupture, not release, because they don't necessarily contain a viable egg, so that triggering system doesn't work so well, and they can turn into cysts. So you tend to see these slightly unusual appearances to the ovaries as they tend to run out. Do cysts affect ICSI treatment, getting pregnant? Well, they can do, but again, what kind of cyst? Where is it? Is it a cyst or is it a follicle? How is it secondary infertility when it's not with the previous father? So, what's the difference between primary and secondary infertility? Primary infertility is where you have never had a pregnancy. Regardless of the outcome of that pregnancy, you've never had a conception, miscarriage, ectopic pregnancy, loss, termination, or live birth. Secondary infertility is where you have had a baby before or a pregnancy before, whatever happened in that pregnancy. So, what I do is I regard primary or secondary infertility as being an individualized thing. Has that person given gametes, be it eggs or sperm, that have resulted in a conception? And then for me, that person would fall into the secondary infertility bracket. And certainly from a medical point of view, from a conceptual point of view, that's a far more useful matrix. You could make an argument that a woman who's had a baby before, who's then in a new relationship, and they are not conceiving or experience primary infertility as a couple because that couple has never conceived themselves. That appears to me to be a semantic issue. I think it's irrelevant, to be quite honest. Knowing that that woman has conceived, be it successfully or otherwise in the past, tells me certain things about the function at that time, at least, that there was at least one tube open, that ovulation took place, that implantation took place. There's a whole lot of really useful information there which can help direct testing and treatment. So it's important information to have. Again, labeling, guys, come on, it's probably not important. Hi, Dr. Kennedy. In your experience, does PCOS have an effect on egg quality? Many thanks. This is a tough one because yes, the answer is yes, it can. So we would see frequently younger women, like late 20s, early 30s with high ovarian reserve, where you know you've got a really good chance of getting lots of eggs, and you know that a proportion of them, maybe 15 to 20% of them, will have diminished egg quality. Really difficult to pick out who that cohort is if you aren't doing actual fertility treatment, trying to generate embryos. But it can be, and something we do try to counsel people about is that, look, there's a chance that your eggs are of worse quality than somebody else your age. The answer to the question, do I have an egg quality issue, is always yes. You're a human being. All human beings have egg quality issues. We're not fertile creatures. We don't have litters. We don't have multiple children every year. We're not cattle. We're not mice. So it's a question of degree. Now, oftentimes you can have people who have diminished egg quality, but you're getting more eggs, so it kind of balances itself out a little bit. And I have had unfortunate edge cases over the years where you've got loads of eggs, and it's quite simply a disaster in terms of fertilization or embryo generation. You try to be honest. The only way you can learn this is by trying it, unfortunately. For the most part, people who have lots of eggs tend to get good results, and that's certainly been our experience over the last year here with our patient population. Thanks be to God. I stopped taking pills 2 years ago and was taking them since I was 15 years old, and now I'm 37. How hard is it to get pregnant in my case? So again, I've got limited information there. Are you having regular unprotected intercourse? Are your tubes open? What does the sperm look like? Let's never forget, 40 to 45% of the time when a couple are struggling to conceive, there's an issue with the sperm. So, and are you ovulating? What's your AMH? We talk about testing all the time, and the tests are actually pretty simple, guys. It's checking an AMH, it's doing some other little blood tests, nothing too complex. It's checking the tubes, it's checking the womb, and it's checking the sperm. And if I have all of that, I can give you a much better steer on whether I think there's a problem here that's going to stop you from conceiving spontaneously. And indeed what your chance with IVF and ICSI are. Do there have to be cysts for a diagnosis of PCOS? Well, no, obviously, because you don't need cysts to have PCOS. So again, you're falling into that spectrum. I have all the other features, but my ovaries don't look like it. So, suffer with adult acne and excess hair growths. Yeah, so you'd look at a hormone profile there and go, is your testosterone high? Is your sex hormone binding globulin low? What's happening with your DHEA? There's various other hormones you can go on. Also, if you have these problems and you've been on the pill, did the pill suddenly fix all the problems or did they continue? So yeah, absolutely, you don't need to have that classical picture on ultrasound scan. Why not try IUI before IVF for somebody who's previously given birth without issues? Yeah, absolutely, why not? Well, it's certainly an option, but maybe it's a less successful option. Maybe you're paying for your donor sperm and donor sperm is really expensive. Maybe you've given birth without issues before, but you're in a new relationship and there's sperm issues. Maybe you're that bit older and your ovarian reserve is that bit lower and time is running out. So you want to try the treatment that's associated with the highest success rate in the first instance. We don't tell people what to want. We're dealing with couples and very, very vulnerable women, very vulnerable couples who really just want to get across the line. What we try to do in a very honest, open and transparent fashion is break down what we think your given chances are any given month, either trying yourselves or with IUI or with IVF. We try to break down the costs, not just the financial, but the physical, the emotional costs of doing treatments. Then you go away and you decide what you want to do. Knowledge is power here. Always, always, always. So the more information you have, the more informed you are, the better off you are able to manage your own journey. Very often I will say to people, look, the decision of what you do is actually secondary to the conversation you have with your nearest and dearest, with the people who love you the most, who are close to you in your life, about what you want the next 3 months, 6 months, 9 months, a year to look like. How urgent is this? How much effort do you want to put into it at the front end? Is there a link between poor egg sperm fertilization rate and PCOS? 41 collected, 5 fertilized. Yeah. So this is the edge cases I was talking about. Now you still got 5 fertilized. So, so the $1 million question is, from the 5 that fertilized, how many embryos did you make? Did you get a baby? Because maybe for you, it took 41 eggs to get 1 baby. And then I suppose, looking at it from the other side, weren't you lucky that you were able to get 41 eggs? It swings and roundabouts. Not every case is the same, but this may be somebody whose PCOS picture is having an impact on their quality. Recurring cysts post egg collection and OHSS, delaying FET, anything I can do. So this is very different to PCO, where you get cysts that form after an egg collection. You take the egg out, but you collapse the follicle that the egg was in, but then it fills with fluid, and these can turn into cysts. They tend to disappear by themselves, but putting you on the pill, or there are various medications you can try to give. You do a scan, maybe do a couple of hormone checks, and then try to make a plan from there, try to accelerate that process, because this is the same person who got 5 eggs fertilized, and that's great, which means they've got an embryo for transfer. Boolabus more. This is great. So what we want to do is try to get the ovaries into a condition where they're not going to interfere with the lining, and you can just crack on, do a transfer, and hopefully get across the line. Can a cyst hinder your IVF chances? I think we've touched on that. Hypothetically, if I presented to your clinic with multiple ovarian cysts and diagnosed PCOS, can I start the IVF process immediately? Ooh, that's a loaded question, isn't it? So we try not to have waiting lists, but we're working with biology here. So what are the other factors here? What age are you? What's your AMH? What's the sperm like? What are the tubes like? What's the womb like? We try to exploit as much as we possibly can. We try to work with the enthusiasm and momentum that brings you into the clinic in the first place. We don't delay people artificially where at all possible. So you can start the IVF pretty quickly. I'm always wary of that word immediately. Pretty quickly. Secondary infertility is when the same couple can't conceive according to my clinic. Is that wrong? I mean, I can argue the toss with you, but I would say that that's wrong. Yes. I mean, I think I would regard infertility as being a more individual than a couple thing, because that has more relevance medically speaking. But I take the point. Why would a 30-year-old who already had a child with a different partner do IVF first with, I don't know the end of that one, with new partner potentially is what that says perhaps. Well, each circumstance is individual, isn't it? Maybe there's a host of different reasons why you might. I touched on them earlier. Age, ovarian reserve, chances of success, cost-benefit analysis in terms of coming into a clinic, engaging with treatment. Everybody's journey is their own, guys. That's all. And you have to, I think you've got to give people their head and you've got to inform them, and then what they decide to do is within reason, within KPI, within ethical standards of care, what they want to do is the right thing to do. I'm 32, single, and PCOS. What should I do? So this is somebody, right, you're 32, you're single. I think you should get your fertility checked. I think the PCOS is a separate issue entirely. I think you should be fertility aware. I think you should get checked. I think you should, at the very least, get your AMH done, because I think all 32-year-olds should get their AMH done. I sound like a broken record on this one. After that, what should you do? Well, it depends what you want. Is having a family important to you? When are you going to have your family? You know that you're single now, you're going to start a relationship. Maybe you want to explore that relationship for a year or two before you do anything. Fertility preservation may be an option. Or maybe you'll do some testing, you'll find actually maybe you don't have PCOS, or as you think of it, PCOS. Maybe your ovarian reserve is low and you need to upstate that. So get informed, get information. That's the critical thing. How ethical is it to offer IVF to people who've just been together just over a year? I think it can be quite ethical. I mean, I'm hardly going to say no to that, am I? Everybody's case is different. You don't have to earn the right to become fertility aware. You don't have to beat yourself to death with month upon month of misery and no positive pregnancy test. You should get checked. You should get information. Then you should find out, is there a problem that requires IVF or ICSI, a tubal issue or a sperm issue or something like that? Are there cysts in the ovaries? Do these need to be taken care of? And then maybe you'll fall into the unexplained bracket, which is really a double-edged sword, because it's kind of crap, because it's very frustrating. Nobody's telling you what the problem is, but of course nobody's really looked at the egg quality, which we know is a critical determinant of success and failure. How do you look at egg quality? Well, unfortunately, the best way of doing that is take the eggs out and turn them into embryos and try to make people out of them. That's what IVF or ICSI is. So it can be very ethical to do this because it gives you a whole pile of information. Now, what are the costs? They're physical, financial, and emotional. So you need to be fully informed of what these costs might look like for you. And then you decide what you want to do. But guys, all I can tell you is from an ethical standpoint of view and how we communicate with our patients, I sleep well at night. How can you extract eggs for fertilization if a patient has over 87 cysts on their ovaries? So again, these aren't cysts. These are little follicles that are present at the start of the cycle. You try to grow them with the stimulation medications. Now, one of the challenges with people who have multiple follicles is that it tends to be either feast or famine in terms of the response. If you give a little bit of medication, they get no response, give a little bit more, no response, a little bit more, no response, a little bit more, no response, a little bit more, too much. You know, they get this explosion and they are at significant risk of ovarian hyperstimulation syndrome. The good news on that is that we've got way better at managing that over the last number of years, and there's ways we can successfully take the eggs out and make embryos and give a specific type of trigger injection to mature the eggs that's not HCG, that's not Ovitrel or Ganassi or Pregnal or one of those that some of you might be familiar with, that essentially switches off that OHSS more or less immediately. So I would have a number of patients who are fairly uncomfortable in the day before egg collection and quite uncomfortable for the 2 or 3 days afterwards, and then like that they turn a corner because we've given them an agonist or a buserelin superfect trigger. So they're at very minimal risk of OHSS. That means we can't do a fresh transfer. But that doesn't matter because the freezing technology for embryos has got so much better that the success rates aren't compromised, but the safety is kicked up. You get as many eggs as you get. So like we generally say anywhere between 5 and 20 eggs is normal, but of course everybody's different and you try to pitch it. Some people will get 20 or 30 or 40 or in very, very rare cases, even higher numbers of eggs. You're not pitching for that many eggs, you're not, but you're just managing the patient in front of you. But you absolutely can extract eggs from people with very enlarged ovaries. Is there a difference between polycystic ovaries and polycystic ovarian syndrome? I think we've done that. Is it ethical to promote someone who's lied to you about secondary infertility? Lads, That's all I'll say to that, lads. Oh, here's a good one. Would it be necessary to do PGTA if you have PCOS, considering the higher percentage miscarriage with PCOS? So, higher percentage miscarriage with PCOS, that's because you have a cohort in there who have egg quality issues, and so that's going to lead to a higher rate of chromosomal issues in those embryos. I don't know if it's necessary to do PGTA, but one cohort of patients who may get benefit from PGTA is younger women who are going to make lots of embryos. It means that you might be able to use those embryos a little bit more coherently and get across the line potentially faster. We don't do PGTA here. So why am I talking about it? Because I think for some people it's reasonable. What you need to understand is that it massively ramps up your financial costs. It's night and day, the difference between doing the cycle here and doing the cycle pretty much anywhere else incorporating PGTA. I would generally, as a rule of thumb, I'm open to be correct on that, say it's twice as expensive. So it's something to think about. Generally speaking, with younger women, with higher numbers, with good egg quality, they tend to do pretty well without PGTA anyway. You tend to get across the line fairly quickly. Do women with PCOS tend to have fewer healthy eggs? Again, for the most part, no, but it's possible. If there are no cysts found, is it still hard for women with PCOS to conceive naturally? Well, it depends. It depends on what your cycle is. It depends if you're ovulating and on all the other factors. What negative effects does metformin? Metformin is medication used in the treatment of type 2 diabetes, and it's also has been used in the past in people on the PCOS spectrum. Sometimes, in some cases, if it can help regulate the cycle, get you ovulating more regularly. In some people, it doesn't make a lick of difference. It doesn't, I think, it's not detrimental to egg quality. I don't think it increases the risk of miscarriage. The side effects from it can be pretty unpleasant. I think it's often worth trying in certain cases, but it's not something you should beat your head off the brick wall with. If you're not tolerating higher doses, drop back to lower doses. If you're not tolerating lower doses, stop it altogether. It's not the be-all and end-all. I like this one. Surely in a scan or internal, the gynae wouldn't be able to count 90 cysts. Yeah, I could. It'll take me a while, but 90 across 2 hours is only 45, and I can count that high. You take your time with the scan. You do it properly. You get coherent information. You transmit that to the patient. I'm sorry to be facetious. I'm not trying to be dismissive. I'm not trying to be... But of course you can. Of course we can. How can you have IVF with polycysts? Well, you can. Of course you can. If you've got polycystic ovarian syndrome, maybe you don't need IVF. Maybe there's medications you can take, which if you get ovulation regularly, will give you a shot at spontaneous conception. We're very open about recommending that for some people. But the chance of a spontaneous conception each month is still low. It might be anywhere between 15 and 20%. And maybe you're not happy with that because now you're going for scans, you're taking medication, and you still have an overall relatively low chance of getting across the line. 3.5 centimetre dermoid cyst on right ovary, family completed thanks to IVF. Should it be removed? Not necessarily. It might cause problems. One of the problems with the dermoid cyst is that it's heavy, and what it can do is it can twist the whole ovary around, and think of it like an apple on a tree or a pear. It can cause what's called ovarian torsion, and that can cut the blood supply off to the ovary. Aside from being horrifically painful, you can lose the whole ovary. So it's something to think about removing. Your family's complete. You probably don't need to have it removed, but at the very least, it needs monitoring. And if it's easier, it sounds crazy, and I don't mean to be blasé, I'll do surgery instead of ongoing monitoring, but you probably need to do one of the two. Can I get IVF even though both ovaries have cysts on them? So yeah, you can, is the broad answer. That isn't in and of itself an absolute contraindication to IVF, but what kind of cysts are they? What else is going on in your history? Guys, that's it for the questions. The one thing I've taken away from all these questions is the vast amount of confusion that exists out there about what PCOS is. The internet may be your friend in this, and there's a lot of good resources, but the core takeaway is polycystic ovarian syndrome should never have been named cystic, because it's not cysts. And as always, the underlying message is, if you're concerned at all, or even if you're not concerned but you want the information about your fertility potential, about what options are open to you, get checked. Don't just come to us. Go to your GP, go to your primary care centre, go anywhere. Come to us if you want, of course. Please ask the questions, get the information, get yourself informed, and then whatever you decide to do ultimately be the right thing to do. I do hope this has helped. Mind yourselves.